Good afternoon and welcome to Families USA's Health Action Network webinar on Medicaid waivers, strategies to address barriers to Medicaid. I'm Patrick Willard. I'm the Senior Director here at Families USA for State and National Strategic Partnerships, and I'd like to welcome everyone today to hear about what's going on in the world of 1115 Medicaid waivers, especially around the barriers that are being proposed by different states and that have recently won approval by the Office of the Department of Health and Human Services and CMS. We'll be hearing today from 3 different state advocates talking about how they have addressed waivers that have come from their states and the strategies that they use to focus on those. We'll be hearing from Adam Fox, who is with the Colorado Consumer Health Initiatives, from Patrick Ness of Minnesota, who is with the This Is Medicaid Coalition in Minnesota, and Marquita Little with the Arkansas Advocate for Children and Families. And then finally, we'll wrap it up with Dee Mahan, Families USA's Director of Medicaid Initiatives, to talk more about what's going on in the world of Medicaid waivers. This is an issue that has arisen just really within the past year. There were some states that had initially proposed Medicaid work requirements prior to the election in 2016. But action wasn't taken on those and some of these other waiver barriers and restrictions until the Trump administration in the past year. Since that time, we have had at least 4 states where a work requirements Medicaid waiver has been approved. We know that those work requirements are now being challenged in the case of Kentucky by 16 plaintiffs who have filed suit. That lawsuit is going to have an initial injunction preliminary hearing in the federal court here in Washington this Friday. And so there will be some indication, we think, in the coming weeks about what the federal courts here in D.C. Think about the proposed work requirements that are part of the Medicaid waivers. In Kentucky, those Medicaid waivers are due to begin on July 1st. That's the reason that this preliminary hearing coming up this week is so important. But we thought now would be a good time to talk with state advocates and others across the country about what's been happening not just in terms of the Medicaid departments and the waiver proposals in CMS, but also on the ground in the states. When a Medicaid proposal initially arises, how states are dealing with it, and what are some strategies and tactics that can be used to combat restrictions in Medicaid waivers. So we're going to start off today with Adam Fox with the Colorado Consumer Health Initiatives. In Colorado, he'll tell us about how they dealt with a proposal from leaders in the legislature to move a work requirement legislative effort in that state. So Adam, I'll turn it over to you.
Thank you, Patrick. As Patrick said, I am with the Colorado Consumer Health Initiative. We are a membership-based policy advocacy nonprofit 501c3 here in Colorado that really looks to improve and protect access, affordability, and equity in healthcare. And so I was asked to talk a little bit about how we approached the Medicaid work requirements conversation here in Colorado and ultimately were able to defeat the bill that proposed applying for an 1115 waiver from Colorado. So before we jump into sort of the details, I think it's important to provide a little bit of context because I think Colorado found ourselves in a little bit of a unique situation compared to many other states that have been dealing with work requirement proposals. So I want to acknowledge a little bit of the context that we were working in before our legislation really hit here in the state. We have a split legislature. Our Democrats have a comfortable majority in the House, and Republicans control the Senate by a narrow 1-vote majority, which ended up definitely playing a role in the conversation, I think, as far as how some of the Republicans were perceiving the proposal and potential electoral consequences come November. Our Medicaid system is also largely handled at the county level. The counties are really responsible for determining eligibility status for people who are applying for Medicaid, as well as other public programs like SNAP and cash assistance. And our Medicaid expansion, which this bill ended up really trying to target, though it ended up being written very poorly, is funded in a little bit of a unique fashion. We have a hospital provider fee that helps sort of gather our percentage of the 90-10 match with the federal government. And that means that our Medicaid expansion really doesn't touch much of our general budget or general funds because that hospital provider fee is now held separately from our state budget to draw down those federal dollars. So that ended up also playing a role because that affected sort of the quote-unquote savings that Republicans thought they would see with a Medicaid work requirement proposal. Also, we have a Democratic governor. Governor Hickenlooper, however, has not always been the strongest messenger on healthcare topics, even though he was very much in the news in September, October, November, while he was working with Governor Kasich in Ohio to come up with some sort of bipartisan proposal to stabilize insurance markets and stop the repeal efforts. At the same time, he has been relatively squishy as far as when he's talking about Medicaid issues. And in early this winter, in January and February, he was quoted multiple times in our local media that he wasn't opposed to work requirements, and he was also using sort of the freeloader terminology and language to describe some Medicaid recipients, which is very problematic. And that meant that we were already sort of engaged on this topic well ahead of when the legislation really hit here at the state level. We still have sort of a local protector care coalition that worked very hard together during the repeal fights last year. And many of those people were quite willing and ready to engage on this particular issue and work to respond to Hickenlooper prior to the legislation and then also once the legislation hit. And just to give you an idea of sort of who's in that coalition, we have folks from labor organizations, fiscal and economic groups, our federally qualified health centers, disability advocacy groups, children's advocacy groups, organizations representing people of color, physician association groups, faith-based groups, mental health focus groups, LGBTQ focus groups, voluntary health organizations, Planned Parenthood, etc. So we have a pretty broad-ranging coalition that was already sort of primed and ready to engage. And we also had been working with several folks locally who could really speak to how Medicaid work requirements would affect them directly as people who were on the Medicaid program. So in late March of this year, we knew that there was the possibility of a Medicaid work requirements bill happening, and it hit in late March, which also happened to be right when our state budget was being debated in Congress, or in our legislature, which I'll talk a little bit more about. But we had a very short turnaround time between when the bill was introduced and its first hearing a week later. And what we did when this bill was introduced is we immediately called sort of an emergency coalition call for all of those folks who were able to participate. Being short notice, it wasn't quite everybody in the coalition, but we got a good number of us together on a call and started tasking out sort of the responsibilities and designing the strategy that we wanted to take in opposing this bill. We tasked out different organizations and groups creating a fact sheet, gathering sign-ons for that fact sheet against the bill, solidifying our messaging and sharing that broadly throughout the coalition and beyond, putting a call out for additional stories from people who would be affected, and sort of organizing our media outreach, advisories, statements, all of that, and who was doing what. We also were organizing and prepping testifiers. We had some folks who were tasked with outreach to groups outside of the coalition as well, which ended up being a huge component of how we defeated this bill in the end. We also made the decision to sort of pull together a very quick rally at the Capitol right before the bill hearing that afternoon. So the timing worked very well to move people from that rally into the hearing, which also meant that we had a lot of spokespeople and folks who were ready to testify. Now, I mentioned the state budget conversation because that meant the timing of this bill was both a little bit of a blessing and a curse, because it meant a lot of the oxygen in our Capitol was being sucked up by budgetary debate and what was going to get funded and everything like that. And it also meant that most of the nonprofit lobbying teams were focused very much on the budget, and it meant that their attentions were a little bit distracted from this Medicaid work requirement proposal. But it also meant that there wasn't a whole lot else besides the budget going on at the time. So it meant that for those of us that weren't deep in the budget conversation, it allowed at least some capacity and flexibility for folks to engage on this issue where they might have been distracted if the budget weren't sort of sucking up all the other oxygen. The bill ended up being assigned to a less unfavorable committee. I say less unfavorable because this was in our state Senate where the Republicans have a one-vote majority, which meant they could have sent it to a committee that leadership could have guaranteed it would have passed through committee. But they assigned it to our Senate Health and Human Services Committee, which is known for having at least one potential swing vote, and I would argue two, which I'll talk a little bit more about. But one of the big things that we ended up doing in sort of all of this preparation for the bill hearing and the rally is that we did a whole lot of outreach to groups outside of our coalition. And in particular, we reached out to counties who would be responsible for implementing the work requirements and ended up being a very important voice in the testifying process. We also reached out to a sort of larger health policy coalition table that had formed early on in the days of the repeal fight but had been sort of dormant. We reached out to insurers, the hospitals, the various physician groups and medical society foundations. We also had the Nonprofit Association engaging volunteer organizations, our dental association, direct service groups, public health associations, substance use treatment, and also education groups. So when we looked at how we were going to message this bill, we knew that we needed some messaging that was going to push back on some of the conservative talking points, as well as some talking points that would encourage sort of more supportive audiences to engage on the issue. So we used sort of a mix of these points that I provided on these slides, which I'm happy to have sent out later, so don't feel like you need to write them down or anything. We used a combination of these messaging points when we were talking to different conservative groups or the legislators themselves, and a different combination when we were talking to more supportive audiences. And one of the biggest messaging points for us was the administrative burden and the cost, and really sort of the creation of red tape that the work requirements would have had here in Colorado. And this is where the counties weighing in were particularly influential. Their voice in how hard it would be to really implement the work requirements on just a logistical level ended up really, I think, being the final nail in the coffin of this bill. So that was hugely effective, and that was also one of the points that we tried to emphasize sort of throughout our messaging, regardless of audience. We also framed this as an extension of the attempted federal level cuts during the repeal fights because that served as sort of an energizing force to get people mobilized and organized. But looking more specifically into what the bill was going to do, there was a pretty arbitrary 20-hour threshold for sort of the work requirement, 20 hours per week. And one thing that I didn't mention in the slide here but should have is there was also a 5-year bar, basically. After 5 years of Medicaid eligibility, unless you had particularly special circumstances, you would no longer be eligible for Medicaid. And that really helped us, I think, broaden how we could talk about this bill. That 5-year bar really was written very poorly in the legislation, and it meant that any number of folks could have been sort of barred from Medicaid coverage, including potentially children older than 5, people with disabilities, and low-income families. So there was that sort of allowed us to speak much more broadly of the unintended consequences of the bill, which ended up being also very important. We also, for some of the conservative audiences, put it in sort of terms of how cuts to Medicaid increases everybody else's costs. So sort of the cost-shifting messaging point of if people aren't covered through Medicaid or otherwise, we have to pay for that somehow, and it ends up coming out of other people's pockets through premiums and whatnot. And then we emphasized very heavily stories of how Medicaid had helped people stay or become employed, especially during the rally and during testimony. At the end, we had about a little over 100 folks who attended the rally. I think we had hoped for a little higher attendance, but we were working within a limited time frame. We had over 30 individuals and organizations go up to testify against the bill in panels. There ended up being really nobody testifying in favor of the bill, which I think was very, very telling about how this bill was being approached. And as I said, the county perspective, as well as from Children's Health and Disability Community testimony, was very vital, as well as our Department of Healthcare Policy and Finance that manages the Medicaid program. The funny thing, well, sort of funny thing is the sponsor of this bill in the Senate was also one of the few Republican votes for our Medicaid expansion when that passed in 2013. But sort of through the testimony process, it was pretty clear that he didn't fully understand how the bill was designed and who it would impact. And he even went so far as to say during the testimony process that he might have to vote against it. He ended up voting for it, but I think that just getting him to that point helped sway the other Republican on the committee, who was in a swing district and ended up voting with Democrats to kill the bill. I think a couple lessons that we took out of this were who delivers the message is really key. Having the county voices, having children's advocacy and disability advocacy groups be able to testify, as well as folks like our nonprofit association and physician groups and hospitals. That was very helpful in swaying that one Republican on the committee to kill this bill, and was an important part of our strategy. One of the other lessons we learned is that we need to prepare testifiers for the worst. And that seems like a no-brainer, but the chair of the committee in this instance really was needling into individuals sharing their stories very hard and seeking to discount their stories, as well as going very hard on the freeloader frame and putting some of the advocacy groups on the spot, basically trying to get them to say that they wanted anybody to be helped regardless of whether they were contributing anything to society in any way, shape, or form, which we were able to get around, but I think it was a little bit more of a contentious hearing process than I think we'd anticipated, especially for the individuals who share their stories, which most of our legislators in Colorado tend to acknowledge and ask a few clarifying questions, but largely treat very amicably. And then, of course, we had a whole lot of groundwork beforehand, before this bill hit, and having our pre-existing coalition was really vital to being able to mobilize and draw on other relationships outside the coalition that we had nurtured as well during the repeal fight. And I don't know if we're doing questions now or at the end.
No, this is Patrick. We're going to do questions at the end of all this. So thank you,
okay.
Adam. And so we'll be taking questions in the chat box. If you have questions based on what Adam's just talked about and the way they fought the work requirements in Colorado, or questions for our subsequent speakers, just type them up in the chat box. We'll be noting them as we go, and then have time to respond to all the questions at the end of this presentation. We're going to go now to Patrick Ness, who is with the Waiver Foundation and was part of this is Medicaid Coalition in Minnesota. And as you can see here, there was a editorial congratulations for the work of the scrappy Medicaid coalition that derailed the work requirements. So Patrick, I'll turn it over to you.
Great, thanks so much for having me. And I just want to say we are in Minnesota continuously and regularly inspired by the work going on all over the state. So thanks to everyone. It's been a scary 18 months for Medicaid, but has never been as strong as it is today. Thanks to everyone's work. So I will flip to the next. This is Medicaid as a coalition of nonprofits that started in response to the federal health care threat about 18 months ago. And so we brought together about 50 organizations, advocates, providers across the spectrum to oppose the federal legislation, block grants, and the rest in that bill. We went on to keep that core coalition of about 50 nonprofits, but expanded and had about another 100 partners in this. My co-convener and I, Susie Emmert from Lutheran Social Service, came to the Families USA conference in January, and that actually was a extremely helpful pivot point for us, moving from the federal threat, getting some of the tools and messaging and some of the specifics around the 1115 waivers and work requirements, and we were able to quickly pivot in late January and start preparing for our session. And we're grateful that we did that because there was indeed a bill that came up. Our legislative session, it was the shorter of the biennium, so it was running 3 months, February till the end of May. The context, both the House and Senate have GOP majorities. The Senate just a 1-vote majority and a deeper majority in the House. And we do have a Democratic governor. So in mid-March, the Speaker of the House, the Senate Health and Human Service Chair, and the chief authors held a press conference announcing that they were introducing the work requirements bill. And they very much framed it as a common sense, compassionate approach, providing ladders out of poverty. The governor came out, and he wasn't very familiar with the issue at that point, which we probably could have started on a little earlier and wish we had. He said he wanted to learn more, and he quickly did when he learned more, and some of the partners had the direct conversation with him. He came out very, very strongly against the bill. It moved quickly. The bill passed 3 committees within 2 weeks. And we were fully expecting the bill to move through the final committees to the floor as a standalone bill, and that just never happened. So I hit some of these in the third bullet, sequencing of membership. We really were intentional around starting with some of the long-standing, more moderate, respected groups in Minnesota advocacy and building out from there. And that helped us attract a couple of the health plans and the hospital association, and some of the legislators who wanted to see first what the tone and tactics of the coalition were, and then we reached out to our other friends and healthcare advocates and brought it in. But that was a strategic decision around how we would sequence out the building of the coalition. And the narrow scope, from the narrow scope of our mission as a coalition was to protect Medicaid. And that started with the federal bill and it moved to the states. As we got into conversations around supporting other pieces of legislation, especially proactive ones, it was clear that we were going to have deeper conversations, which we will be doing in the future. We really set a kind of a spirit that if you're going to be at this table, you're going to do work, and everyone stepped up and changed their plans for the year and made sure that they were at the table and they were contributing something. It is a leader-full coalition. Different people stepped up at different times. We did not hold the work close. We coordinated it closely and then spread the leadership out. I want to give a shout out. I see a couple people from Minnesota from our coalition on the line, Dana Bacon from the Leukemia and Lymphoma Society and Laura Mortensen from the Minnesota Budget Project, who are really key leaders in our communications work. So the proponents of the legislation, there were a total of 4 organizations that testified across the 3 committee hearings. Only Americans for Prosperity, a Koch brothers funded advocacy organization that has a Minnesota branch. They were the only ones that testified in all 3 committees. But when you look at these, there is a strain that runs through them of being one, very little connection to health care, either to low-income people or people with disabilities or older adults, or to health care. It's more of an ideological thread through these 4 organizations. It was clear, and we made it clear to anyone who would listen, that this was not a homegrown policy idea. This was something that was coming, an ideological move to take health care away from Minnesotans. At the first committee hearing, it was one of the most emotional, stark, powerful hearings that I've been a part of. And from a couple of these organizations, they flew in a former human services director from Maine, I forget her name, and she was testifying. She talked about how all the elected officials should look at the polling numbers. This is good politics to incorporate work requirements. That did not go over well in the committee hearing, and we were able to quickly get some information and questions around just exactly what happened to the poverty rates and uninsurance rate in Maine during this person's tenure as commissioner. And then the other person, I'm not sure which organization it was, they sent in a lobbyist from the East Coast who, up until 3 months ago, had been an NRA lobbyist, and she was flown in to tell Minnesotans how we should take health care away from from our low-income neighbors. And so that proponent messaging, common sense and compassionate ladder out of poverty, as I mentioned, the runaway government spending is unsustainable, and then really trying to divide between the quote-unquote deserving and undeserving poor, attempting to pit people with disabilities against low-income advocates. And I'm really proud of our coalition for kind of fighting back against that and ensuring that we would not be divided, that we had a kind of a spirit of everybody in, nobody out, and that held true. Our messaging, so we started with costly, complex, full of unintended consequences, and I think that was fairly effective messaging, but we certainly found out that we were only talking about work. Well, why can't this person work, and what's really the struggle with that person working, and don't you think that work brings dignity onto the human person? And so we pivoted halfway through the session, and went back to a strong values-based healthcare message and got pretty granular on exactly what Medicaid was paying for in people's lives in terms of the types of services and medications and equipment. We were clear that the promise of Medicaid has always been, if you are very low income, then health care. If you have a disability, then health care. If you are an older adult in need of nursing home care or other core services, then health care. It's never been, if work, then health care. And so we just tried to stop the conversation without getting into the weeds of the value of work. We also kind of reframed from work requirements and started talking about reporting requirements. Work is, of course, very popular. The polling on this is not great, and so no one likes reporting. And so we focused it, this is a healthcare issue, and then the reporting burdens that come with it. We were clear in talking about taking healthcare away from Minnesotans rather than people who would lose healthcare or something more passive. This was a decision to take healthcare away from our neighbors. Of course, the high fiscal costs of implementing and maintaining this bureaucracy. Minnesota has 87 counties in the state that deliver our Medicaid program. There was a local impact analysis that came out of our state budget office saying that this bill would cost Minnesota counties $160 million a year, every year, to keep up with the cost of this. Added staff, technology, all the IT systems, just the bureaucracy of this. And so we had Republicans after hearing about this, say, I don't want to vote for a property tax increase just to take health care away from people. So our messaging was working. What worked for the coalition, our earned in social media was compelling, and props to those who were leading that work. The stories of personal impact. We had veterans speak. We had a man, Josh, who lived in the car in the district of the chief author and talked about his story, and that moved a lot of people. Our values-based messaging, not giving up on any legislator. We went and had conversations with everyone, and surprisingly, I think that helped kind of chip away at some of the support instead of just assuming their support for the legislation. We eventually got very strong support from the governor. He did say he would veto it if it got to his desk. In conversations with some of the GOP political staff, it was reality testing. We're not really sure that this is the political winner that you think it is. And that was clearly the thrust of this effort. And we know that healthcare voters, this is going to be a healthcare election, and Minnesotans don't take kindly to having healthcare taken away. And that's the frame that we were going to stay with through the election if they move this as a political issue. And then the last bullet, just teamwork makes the dream work. It's one of the best examples of everyone giving their gifts and their talents and just no matter what the task is, taking it on, getting it done. And so we had fun. There was joy in the coalition as we were taking on this ugly issue. This is just one of our little social media pieces that talked about just the overwhelming paperwork. We had another one on the cost to local governments. Here are the over 150 Minnesota organizations that signed on in formal opposition to the bill. And that wraps it up for me. There were a lot of lessons learned from this, and we are just continuing to prepare for threats to Medicaid in the coming months and years, but are just waiting to pivot back to a proactive push to strengthen and expand Medicaid as well.
Thanks, Patrick. Great presentation there, and I think hitting a lot of the points that both Adam and Patrick in the sense of messaging and what worked in terms of messaging, being prepared early, and then finding that fiscal argument that is out there and using that as part of the overall effort to make sure that people understand that this is not something that is going to be no cost to the state, but it actually costs the state to try and take these benefits away from people, focusing on these reporting requirements, as Patrick mentioned there. Now, not every state has had the opportunity to take it up in this legislative session, and some states had their waiver proposals before the Trump administration already at the beginning of the year. And among the 4 that were approved, the first one to go into effect was the work requirements proposal that was approved for Arkansas. And so we have on the line Marquita Little from the Arkansas Advocates for Children and Families to talk about how Arkansas has dealt with the work requirements waiver and what lies ahead. So Marquita, I'll turn it over to you.
Great. Thanks so much for the introduction, Patrick, and thanks everyone for being on the webinar today. As was mentioned, I certainly appreciate all of the work of fellow advocates around the country who are working on these issues. So, like I'm having a little trouble now. Okay, here we go. It's working. So before I jump in and talk specifically about the latest version of the waiver amendment in our state, I do just want to give a bit of an overview or a little background on the Arkansas Works program. So Arkansas Works is the state's Medicaid expansion program for low-income adults, as you all know. A lot of people know it as the private option, and so Arkansas was was the first state that came out with a different model, and so we use the federal Medicaid dollars to actually help pay the cost or the premium for our enrollees to go into QHP, their private plans, on the marketplace rather than traditional Medicaid. And so our legislation has been around since spring 2013 and covers a pretty significant portion of uninsured adults of the state. About half of those folks who are uninsured actually participate in this particular program. I think another important point to mention, and the reason I wanted to give a little bit of background and talk about the structure of our program, is because our marketplace in the state is basically primarily made up of these Medicaid enrollees. So it's been a pretty significant factor in kind of stabilizing premiums, and we haven't seen some of the significant or as significant increases in premiums because such a large portion of our marketplace are these Medicaid expansion enrollees, which was one of the initial goals when the state was discussing this. So our Medicaid expansion legislation was actually approved under one governor and then inherited by our current governor. And so a Democratic governor kind of led the charge, and it was also supported by a bipartisan group of lawmakers. Again, a lot of the reason why we ended up with the private option model was because of some of the concerns, especially amongst those Republican lawmakers, about increasing roles or creating a program that appeared to increase roles in our traditional Medicaid program. So it was a bit of a compromise. Well, then our new governor was elected. We experienced a political shift in the state. We now have had a Republican governor, and a significant number of seats in our legislature also shifted, and we saw a pretty significant increase in Republican seats in our state legislature, nearly supermajority in both chambers. And so we had this program here that was of huge financial benefit to the state, us bringing in those additional federal dollars, really helping to stabilize and sustain our Medicaid program, as well as helping out hospital systems and, of course, significantly reducing things like uncompensated care and just overall rates of people in our state who lacked insurance coverage. So when Governor Hutchinson came in, there had kind of been sort of this push in the background on a lot of lawmakers who really were not fans of the program, but at a minimum, if we were going to keep the program in place because of the financial benefits, they were pushing for much more conservative features, much more restrictive features. And so Governor Hutchinson immediately took on the task of making some changes to the program. We heard a lot of terminology like personal responsibility, skin in the game around those conversations. And so then the last several years, basically this kicked off what was a series of changes to the program, or 1115 waiver amendments. We actually had a legislative task force on health reform that was convened that looked at the Medicaid expansion program in our entire Medicaid program and produced a very lengthy report that included all of these recommendations on how the state could better contain costs in the Medicaid program. A number of those recommendations were not things that the previous administration had approved or things that had been declined in the past. And so this report was sort of sitting on the shelf while lawmakers waited to see if there was a change in the administration. And so that's what we saw after the election, and there was a change. The state moved forward pretty swiftly with what's our latest round of changes to the program. And so the three big components that the state requested were partial expansion, so reducing the eligibility threshold from down to 100% of the federal poverty level. And so that one was deferred or delayed. CMS did not say no, but they kind of said we're still considering. Eliminating retroactive eligibility. And so there was a lot of pushback on that one, especially from hospitals. And so we ended up with a compromise on that. It was reduced down to a 30-day retroactive coverage window. And then, of course, the big one is the work requirement, which was approved for our Medicaid expansion population. So I included here because Arkansas has had a number of different changes over the last several years to our Medicaid expansion program. And you may not be able to see this well, but I just wanted to point out there's a nifty little chart or tool that Families USA has available that summarizes and goes over a lot of the waiver features and changes that and components of those waivers that exist not only in Arkansas but in a number of other states. So you can see, in addition to our work requirement, we have additional cost sharing requirements. We have premiums. We've tried HSA, the changes to the retroactive coverage, as well as healthy behavior incentives, which were never implemented. So that's a big part of really one of the arguments that we used. I was pointing out the number of changes that we've seen to the program and the fact that our system, our healthcare system, they've had to absorb all of these changes in addition to the consumers and beneficiaries having to adjust and be knowledgeable of and aware of all of these new eligibility requirements in the program. We've literally each year had either a legislative or special session where there was a new set of requirements that were approved by our state legislature. So we, of course, have had an advocacy strategy in place to defend against some of these changes. And so, again, the interesting dynamic in our state, of course, is that because of the increase in conservative lawmakers, the governor really has been in a position of trying to figure out how to preserve the program and garner support from a lot of those Republican lawmakers. And so that's really been the push for all of the changes that we've seen to our program recently. And so our advocacy strategy, I'd say, has really been multi-tiered or multi-layered. We've taken on a number of approaches to defending against things like the work requirement. So first, just our legislative advocacy, and so those traditional means of talking directly with lawmakers, testifying, preparing some of our partners and other people to be able to testify as these things have come forth through legislation. And again, the challenge in our state has been to secure those votes. We've seen these new features like the work requirement added, and that was the only way in many cases to secure the vote from Republican lawmakers. We've also participated in public comment periods. In our state, we have, which I understand is not actually required necessarily of a waiver amendment, but we have a public comment period at the state level, and we always formally submit comments as well as submitting comments during the federal public comment period. One of the things that we always do there is also work with a number of our partners. So we try to coordinate with like the Hospital Association, Legal Aid, a number of other healthcare provider groups in our state to make sure that we are sort of comprehensively covering all of the potential concerns or issues or areas where we can at least try to improve the waivers when we are working on our public comments. We've also relied a lot on the media, both using traditional media outlets as well as social media. Those traditional media outlets really ensuring that we are keeping the local press informed about these changes, being able to contribute to pieces that they're doing on it, appearing on some of the local politics-focused TV shows, and also using social media. And our communications director is a bit of an expert at this, but ensuring that we really target the information that we put on social media, and so not just posting something in hopes that folks will see it, but really being strategic about how we use social media and targeting certain populations or audiences to make sure that we have a greater chance of reaching the right population on some of these issues. And also, one of our most powerful tools has been our consumer videos. We try to capture the story of consumers throughout the state. In the past, we've really tried to be strategic about identifying the counties that those beneficiaries are residing in. And so if there are key lawmakers whose vote we are trying to influence, we will oftentimes try and make sure that we have a consumer from their particular district in one of those consumer videos. And then finally, using our coalition voice. So one of the points that I'll make there is that the nature of our coalition has changed over the years because it's a different conversation when you are just trying to garner support from your partners on the overall support of having a Medicaid expansion program versus being able to defend against some of those individual features and components. So to be more specific, we had much broader public support from a lot of entities who supported having a Medicaid expansion program in place. But then there were others who didn't feel as comfortable speaking out publicly against a work requirement because of the political nature of it. A lot of our coalition members felt like it was necessary to make those changes in order to keep the program in place. And quite frankly, some actually agreed with the idea of adding things like a work requirement. And so we've started to work a lot more with some of our grassroots partners who really have trusted relationships with community members, especially in some of those rural communities, and traveling to different parts of our state to make sure that the people who are not as connected to what's happening at the Capitol are able to be engaged on these issues and speak out. So some of the key messages that we've relied on in implementing our advocacy strategy are focusing in on the fact that the work requirements are really politically motivated and that because we are a state with high poverty rates, really this work requirement just completely ignores and doesn't address some of the real challenges that we face in the state because of the lack of meaningful employment opportunities. We've also highlighted the fact that the majority of people enrolled in our Medicaid expansion program are actually already working. They're already enrolled in school. They may have an ailment themselves, or they're taking care of a relative or a dependent child. We've also used the argument that this just adds unnecessary cost or the high administrative price tag associated with this. And we've also talked about the disproportionate impact it will have on people with disabilities that probably will lose coverage, not because they don't meet an exemption, but maybe just because of the bureaucratic red tape. And I can tell you the arguments of those that probably have the most traction, and the same, I think you'll find in some of the national research, is that mentioning the bureaucratic red tape as well as the high administrative cost tends to be the argument that gets the most support. So in the case of Arkansas, of course, we were not able to prevent the work requirement from being approved, and so we sort of have a plan B that we already had ready to go into place in response to this. So one is advocating for the broad list of exemptions. Since we knew that the work requirement was going to happen, we really started to focus our energies on how can we ensure that the least amount of people are actually harmed by this work requirement. And this one was a tricky balance because we didn't want to sort of say too early, we know we've lost the battle, let's try to figure out how to improve this work requirement, because we really needed to strongly oppose it outright. But we were able to shift when we saw that the legislation was approved at a state level. The next piece was engaging in outreach and education. Now that the work requirement is here, again, our goal is really to make sure that consumers who will be impacted are aware. So we've been working with a number of partners to actually go throughout the state, talk about the work requirement, produce outreach materials that are useful and easy to understand to make sure that beneficiaries know how to respond to the work requirement, which was implemented in Arkansas June 1. And the other two things that we've been working on now that the work requirement is here is monitoring the implementation. And so we are working on a monitoring plan where we will assess things like the adequacy of the state's outreach and enrollment. We will assess things like how many people were able to successfully take advantage of an exemption, what types of barriers those people faced. And we also hoped, as a part of that monitoring process, to really create a feedback loop where we are giving active feedback to the state to influence and improve the actual outcome. So not just researching what the impact is, but actively trying to improve and change that system. So we were pretty successful at getting a long list of exemptions approved. A couple of those exemptions are automatic. And so we were able to get some of the important things, like a person who is medically frail, a person who's caring for a dependent child. Those are exemption categories. And one that was added later is a good cause exemption. And so that is really for someone who's already missed the reporting requirement, but maybe they had a major life event happen, a death in their family. They're able to go back and retroactively get a good cause exemption for that month. One of the things that's recently been highlighted, and the state has gotten a lot of public criticism, is that we do not have an exemption for one of our very vulnerable populations, and that's people who are experiencing homelessness. And so we are actively working with that community to try to figure out the best way to address their needs. And just really quickly, I want to highlight who's actually impacted. So there was an Urban Institute study recently released, and based on that study, 74% of people in our expansion program are likely exempt. And so what that means for us is that we need to pay really close attention to that population, because even though they are exempt, we have the concern that people will fall through the cracks because they don't understand how to take advantage of those qualifying exemptions. We also know that about 12% might be exempt because they're already working, but that poses concerns like, are those people working consistently? Are they seasonally employed? So again, even though these folks might be exempt, one of the difficulties is going to be them understanding this new system and how to report. And then finally, just a few lessons learned. And so I mentioned that elevating the consumer's voices really has been a very powerful tool for us, really talking about the real-world impact of these policies, particularly the work requirement and some of the challenges and barriers that people will face in meeting it. Also developing a strategy that has multiple approaches.
And so as you could see from the advocacy strategy slide there, we've tried a number of different approaches when we were not actively in session. We were still pushing back and also preparing for that next stage, which is the next lesson learned, planning for the worst case scenario. So the work requirement was approved in Arkansas, but we were already ready and already prepared to start that outreach and education piece, and we are now working on putting a monitoring and evaluation plan in place because we want as much data, as many consumer stories as possible, so that when the opportunity presents, hopefully to reverse course on this, we will be prepared with that information. And then the final lesson is to be persistent. Certainly, this in some ways feels like a little bit of a loss in terms of losing the battle on the work requirement, but we are going to continue to forge ahead in hopes of, again, that we can help with educating consumers about the work requirement and ensuring they know how to take advantage of those exemptions so that they don't lose coverage. And again, we also hope that we can reverse course on this if we've collected the right information to show how devastating an impact it will have. And so I'll end there because I think we're going to take questions at the end.
Right. Well, thanks so much, Marquita, and I think it's really valuable, especially in terms of first dealing with the issue on the front end, but also thinking about how you're going to evaluate what ends up happening now that the work requirements are in place and what that's going to mean. I'm going to turn it over now to Dee Mahan, who is our Director of Medicaid Initiatives here at Families USA.
Okay, thanks, Patrick. And I have just a couple of slides I'm going to go through, and I'm going to do these kind of quickly, but if you have questions after the fact, you know where to find me here at Families USA. We've just heard from people working in 3 very different states, but there are common themes. First, this guy might be coming your way. No matter what state you're in, restrictive waivers are something that you should be prepared for. We've got some numbers here. A lot of states are looking at these. Legislation in over 20 states, this was considered during this legislative session, the issue of work requirements. It's an issue that cuts across expansion and non-expansion states. And not only is this something that's moving across states, it's also something that's likely to become part of a federal debate on Medicaid as well. Last year's ACA repeal efforts included adding a work requirement to Medicaid. This Friday there's a hearing on Kentucky's Medicaid work requirement, as Patrick mentioned at the outset. And that's the first step in a legal process that could decide this matter as far as CMS waiver approval authority is concerned, but that doesn't necessarily end there because it can still come back in Congress as part of a legislative debate, and it likely will. So no matter where you are, this is something you should be prepared to advocate on. And your advocacy matters. That's something that we've also heard very clearly from our speakers today. Engaging and building your coalition and cultivating legislative support at the state level needs to start early. Your chances of stopping or changing proposals is best before something is approved by the legislature or out for state comments. But that said, your advocacy needs to continue, and it is important throughout. The approval and implementation process builds in a lot of advocacy points, and you should use them all. During the state comment period, organize and get lots of comments. Numbers do matter, and they can really show where the public support falls. I'll focus on state issues as you're talking about this and stories of people who stand to lose coverage. We've heard that from Arkansas. Tell stories of Medicaid success. This is also an opportunity to educate the public about the importance of Medicaid and set the stage for repealing any legislation or withdrawing a waiver later, and also for building broad public support for Medicaid and lay the foundation for future federal advocacy when that becomes necessary. Federal comments are important too. They're part of an administrative record that plays a role in litigation, and it also helps guide future administrations. After a waiver is approved, advocacy should continue. If you can work with your Medicaid department to get a consumer-friendly program as possible, you should do that because there may be some ways to make any waiver that gets approved less onerous for consumers. And remember that waivers can be withdrawn or amended at any time. So you need to keep up the advocacy, tell stories about the real people who are being hurt. Federal law requires a certain number of post-implementation public forums, so use those to keep the press engaged. Also, see if there are any universities or think tanks in your state that can take this issue on and publish studies about the health and economic impact of waivers on families losing coverage and on providers. Because this is all part of laying the groundwork to change any programs that do get approved and implemented, and also holding legislators accountable for their votes. And Families USA is here to help connect you to advocates across states. We've developed a Waiver Strategy Center that's designed to help you stay informed. It includes materials to help you draft state comments, information on state waivers, tools for building arguments against waiver proposals. This is all to help you learn about what's happening across states as you set your strategy. So please check that out, and also please give us feedback. We'd like to know how it's working for you and what we can do to build a better support center for you, because your advocacy is critical. There is a political agenda here. This is all part of remaking Medicaid. It failed at the federal level last year, so they're trying to do it administratively one state at a time. And we need to step up and stop that process. And as we've heard from our presenters today, it is something that we can do.
Thanks, Dee. So we have a couple of questions, and I'll take those and then wrap up. One of those, I mentioned at the beginning that we have the lawsuit that's been filed in Kentucky that will affect the work requirement program that's in that state, and theoretically could apply to other states and their work requirements. We do have a question, Marquita, about Arkansas and whether there was a consideration of doing a legal challenge to the waiver in Arkansas. So could you respond to that?
Sure. So, of course, we're kind of patiently waiting to see what the outcome will be of the Kentucky lawsuit. And definitely there are groups, and certainly it wouldn't be our group because we don't participate in kind of legal advocacy, but there certainly are groups, both probably locally, I would say, and nationally, who are monitoring the situation in Arkansas. And so I think that we could certainly see that as a potential strategy in the future.
Great. Thanks so much. And then we had another question about whether it's possible to convince Governor Snyder to veto the work requirement bill that recently passed in Michigan. I know that Michigan groups are calling on the governor to veto that bill. We and other national groups have been encouraging folks to reach out to the governor in that state and to ask him to veto it. There were press reports that the governor had signed off on it, but it hasn't been signed at this point, so we'll see what happens in terms of Michigan. Let me say finally that we appreciate Adam and Patrick and Marquita as well in participating in today's program. I think there are some valuable lessons to be learned, and we're going to make this webinar available on our website so that people can access it. We'll also be sending out the PowerPoint deck to those who have participated in and taken part in this presentation so that you can look at that. And of course, you can always contact us at Families USA if you have additional questions about anything regarding waivers and work requirements or other restrictions that have been proposed out there to make these programs to place barriers for those people who could rely on the Medicaid program. We'll continue to do a lot of work on the waiver side, so reach out to us here and check out the Waiver Strategy page to get some additional ideas of different arguments against these restrictions going forward. So let me say thank you to everyone for participating in today's webinar. We appreciate all your good work and look forward to talking to you in the future. Thank you.